question is interesting because I'm in the process right now of putting together my curriculum for my advanced fixed prosthodontics residency program that starts at the end of the month. And so the question really is about how I use QuickSplints to establish or to get patients used to their occlusion. Well, I don't really use the QuickSplint that much post-operatively, but I use it extensively kind of in the preliminary phases. So if I need to relax muscles to get good registrations for the diagnostic phase, QuickSplint is my go-to technique for getting patients relaxed so I can get some fairly accurate interocclusal registrations. We do a thing called matrix bonding. It's kind of established new occlusion in kind of a temporary way. So we use QuickSplints to protect that. We also use it to protect provisionals in some instances. Again, it depends on, are the muscles getting relaxed and our patients adapting. But we want to make sure that we stabilize and get the patient comfortable really before we finalize the occlusion. And so we really use the QuickSplint really more in the preliminary phases rather than post-operatively.
The QuickSplint is one of the most important tools when doing a full mouth reconstruction. First, we like to use it when the patient's in the provisional phase. That way we don't have to worry about provisionals breaking or popping off, especially if the anteriors are veneers. The nice thing about that is that it allows more muscle settling and relaxation. So when it comes time to deliver the final case, we can be assured that the patient is in a orthopedically stable and comfortable position. After delivery of our reconstruction, we also fabricate another QuickSplint. And we do this to protect our work, make sure everything's dialed in as the definitive night guard is being fabricated. So when we deliver the final night guard, we have another chance and opportunity to evaluate the occlusion. This ensures that we're properly seated joint position, the bite is comfortable and fully protected. And if we need to do any touch-ups at the delivery of the definitive night guard, then we can do it. But getting there, the QuickSplint is just a wonderful tool for us to use.
Hi, Mike Smith from Biting Education and Clinical Mastery Series. Well, the question is, when you have a full mouth reconstruction case, how does QuickSplint help your patient adjust for their occlusion or just having the patient go without? Well, when we put in a whole full mouth reconstruction, there's a lot of changes for the way they bite, the way they chew, the way they function. You got to make it so they can adapt to that new position much easier. Well, one of the things that happens is when you put all this case in, you can get some inflammation of the joint space. Well, inflammation will change the occlusion. Well, the best thing about QuickSplint is it's going to help them mitigate that inflammation, especially at night when they're clenching, grinding, parafunctioning. And it's going to help to decrease that inflammation, allow them to settle their occlusion faster and not have as much inflammation.
Supported full arch restorations. Usually if patients are breaking their provisionals, it's really diagnostic and shows that they do have possibly some occlusal problems, or maybe the design of the prosthesis just isn't correct. And so a lot of times it's just the patients, when they haven't had teeth and they got a whole new arch full of teeth, it takes them a little while to adapt. And the QuickSplint can be useful to protect these prostheses, but also to relax the muscles. And so you can develop a good, stable occlusal position. And so once you've got a good stable occlusal position determined, then it really, if you have any failures, it's more a matter of just prosthesis design.
The All-on-X prosthesis is a unique beast. For most of the patients that need restorations like this, many times they're missing a lot of the posterior teeth. And we also know that it requires posterior teeth to be in contact to fully recruit the elevator muscles. Occlusion is nothing more than the science of force management. So once we give people all these teeth that they can bite and clench on, now they're going to get recruitment of those crusher killer elevator muscles. So the QuickSplint allows us to manage the forces by reducing the elevator muscle activity by up to 70% by just having the pressure on an anterior appliance. And this allows our patients to go through the provisional stage, the testing stage, without breaking their provisionals, which is a godsend for anyone who has a busy practice, that they don't have to have patients call at the last minute and fix them. So it's a wonderful tool to have in the toolbox.
Hi, Dr. Mike Smith from Biting Education and Clinical Mastery Series. So the question is, for all on 4 cases, why do some patients break the temporaries? Well, you have to think about proprioceptive response. When you take all the teeth out and you put implants in and you put this bar, you put this overdenture, you put this restoration in place, they lose the feeling of where their jaw's supposed to be, on how they're supposed to connect, how they're supposed to occlude, how they're supposed to hit. Well, when they smash, crash, and bash, they can break things very easily because their jaw doesn't know where it's going. It hasn't trained itself. The muscles haven't trained. There's no neural response. So what the QuickSplint does for us in these temporaries is it keeps them from having that smash, crash, bash that can break the temporaries because they don't know where their jaw is going to be. It also helps to mitigate the inflammation of the joint response because you've done a lot to change their occlusion to rebuild it with those temporaries on those implants. So it really helps to calm things down, keep the muscles under control, and keep the joint from getting inflamed.
Usually when patients complain about their bite being in the wrong position, they're a pretty good indication of what's right and what's wrong. And anytime you're dealing with, entire arches, if you get the wrong interocclusal registration, or the lab, builds things that aren't the way you want them, a lot of times maybe the bite is off. And some people can adapt to almost anything. Some patients, are very keen on, their bite, and I call it, really have an acute occlusal awareness. But I think the bottom line is, if you can use quick splints and to relax the muscles so you can manipulate the mandible, then you can go ahead and adjust the occlusion so you have a good, stable, centric occlusion. And then the other part of that is just to get good anterior guidance so the anterior teeth separate the posterior teeth when you go into excursions. And so, I don't think occlusion's all that complicated. So if you can get the muscles relaxed, so you can manipulate the mandible, develop a good, stable, centric occlusion with good anterior guidance, and virtually every patient will adapt to that nicely. And the QuickSplint can be very helpful in getting patients relaxed so you can manipulate the mandible. I call it mandibular control.
Most people don't really understand muscle physiology. Most movement around joints require agonist-antagonist muscle interaction. If I want to bend my arm, my tricep has to extend, it has to relax slightly, and my bicep has to contract more. Well, when it comes to the TM joint, the elevator muscle and the opening muscle, which is the lateral pterygoid, don't have that relationship. And that's because the lateral pterygoid has very few stretch muscle reflex receptors. So most AP slides occur on the posterior as patients have to move from CR, CO first contact, into MIP. Now this causes the lateral pterygoid to contract and bring the jaw forward. By using a quick splint and eliminating those posterior interferences, now the lateral pterygoid can relax and go back to its most comfortable optimal position, and this allows us to establish the occlusion. Once we establish the occlusion, then we can make our patients comfortable in their implant provisionals, and then as we transition them to definitive restorations, everything works out really well and everyone's happy.
Hi, Mike Smith from Biting Education and Clinical Mastery Series. The question is, why do patients say that their implant temporaries are putting their jaw in the wrong position, and how does QuickSplint help the patient transition to a new occlusion? Well, as you have inflammation, the bite changes. As they have a foreign material in their mouth, they can hit it weird. They can hit it and they can make parafunction on it. Well, what the QuickSplint does is helps to alleviate that inflammation, allow their neural response, their proprioceptive response to change, to allow them to redevelop new engrams to protect their bite, protect their jaw, and get it so their occlusion can settle back in the best manner. So QuickSplint really helps from the inflammatory standpoint to get it so they can alleviate those symptoms and get it so they can get their bite right as quick as possible.
Yeah, hi, this is Bruce Crispin again, and I think this is a simple question. I've been doing reconstructions for probably over 50 years now. And getting a good interocclusal registration is really the key. And if it's not repeatable, you probably don't have an accurate one. And usually it's not accurate because either the muscles or maybe you got some tooth interferences that are deviating the mandible from whatever position you want to get your interocclusal registration in. But one of the biggest problems really is just, muscles that are, kind of used to biting a certain way, and maybe you want to position the mandible in a little different position, and the muscles kind of tense up. They're used to dodging interferences and so forth, or used to going into an old centric occlusion. And so the QuickSplint really is just a very quick way to fabricate a deprogramming, which just relaxes the muscles. And again, if you can get relaxed muscles, you can get what I call mandibular control. And without mandibular control, you can't get an interocclusal registration that you want to dictate. Okay, if you want them just bite together and use their centric occlusion that they have, that's one thing. But if you want to dictate a centric occlusion, maybe you're building a case in centric ablation and opening the vertical possibly, then you need to have good relaxed muscles so you can get repeatable interocclusal registrations. And getting good, accurate, repeatable interocclusal registrations is really a critical component when you're doing advanced cases. And this is really what we teach in our Advanced Fix prosthodontic residency program here at Aesthetic Professionals, is that interocclusal registration is critical.
When it comes to locating an orthopedically stable and repeatable bite position, we have to understand something. We have to really understand opening and closing. So if you're old enough, like I am, you were taught that the first motion of opening is a hinge. Well, that's simply not true. If you think about it, what muscle opens our mouth? And that's the lateral pterygoid. So the lateral pterygoid has to contract, so we get both a hinging and a translation at the same time. Now, if there's a posterior interference present, then there's going to be even more of a forward shift as your mandible is trying to get past that interference. What the QuickSplint does for us is by disengaging the posterior teeth, right? There's no elevator muscle activity playing this, tug of war between CRCO and MIP. This also allows the lateral pterygoid, since it's not pulling the mandible away from an interference, to relax, and thus that allows us to find an orthopedically stable position, and that's why it acts as a deprogrammer.
Hi, Dr. Mike Smith from Biting Education and Clinical Mastery Series. The question is, can you explain why it's difficult to take repeatable bite records on some patients, and why does using QuickSplint as a deprogrammer correct this? Well, it all has to do with muscle engram memory of where their bite is. It also has to do with inflammation. So as the patient has these engrams that are telling the jaw to, hey, hit this way or you're gonna break something, it really helps to reprogram those memory engrams in the proprioceptive response to get it so that patient can have a good feeling of bringing their teeth back together without having that hit slide, that protective response. The QuickSplint also helps to decrease the inflammation in the joint space and gets the muscles to settle back down because you're decreasing the force, the activation of those muscles to allow them to calm back down, get the muscle engrams right, get the inflammation correct, and it really helps to deprogram these patients so you can get an accurate, repeatable, reproducible bite record to rebuild your cases or to do your diagnostic records to find out what you need to do. Fantastic deprogrammer, and it's very easy because you make it chair side, only takes 45 to 55 seconds, and they're good to go.